So the next talk is glycemic management in post-operative days. So may I invite Dr. Neelam and Dr. Sweety.
Good evening. Thank you, chairpersons, and thank you, organizers, for having us here. It's always a pleasure to come back to the SPEEDCon. So without wasting much time, I know this is the last session before dinner. We'll start off with our discussion tonight. So we are going to talk about glycemic management in the post-operative days. So the plan of discussion goes like this. We first talk, obviously, any post-operative management is incomplete without a basic pre-operative assessment. Then we briefly discuss glycemic targets for patients admitted for surgery, strategies for glycemic control in both critical and non-critical patients with diabetes, and special situations like patients who need glucocorticoids while they're in hospital, patients who are on enteral or parenteral feeds, and last but not the least, glycemic management at discharge and emphasizing of a continuity of care at home. So, having diabetes itself predisposes patients to surgeries themselves. Diabetes, as we know, is associated with micro and macrovascular complications, thereby predisposing patients to surgical interventions. In fact, data says that around 25% of patients worldwide with diabetes would require some sort of a surgical intervention in their lifetime. Moreover, even in the absence of a pre-existing diabetes, around 10 to 15% of patients would develop a stress-induced hyperglycemia perioperatively. This is then followed with an increased risk of perioperative infections as well as post-operative morbidity as well as mortality. So, Dr. Neelam, what do you think is the importance of glycemic control in the perioperative period and factors affecting it?
Thanks for the question, Dr. Sweety. As we all know that good glycemia is key to good surgical outcome, and the pathophysiology of surgical stress which contribute to hyperglycemia is it leads to counter-regulatory hormone surges where catecholamine, glucagon, cortisol, growth hormone all increases, which leads to reduced insulin production as well as increased lipolysis whereby free fatty acids increase, which reduces the peripheral utilization of glucose, leading to relative insulin resistance, and thereby gluconeogenesis also increases, which leads to increased glucose production in the system, leading to hyperglycemia and ketosis, which whereby affect all the cellular functions and creating vascular changes, mitochondrial injuries, endothelial dysfunctions. It affects our immunity, affecting the neutrophil functions, and leads to superoxide generation, which creates more chances of peri-op infections and poor wound healing. And there are various factors which affect glycemic control perioperatively, such as apart from stress of surgery and anesthesia, it is altered nutritional intake, hyperalimentation, emesis, sepsis, and because of the circulatory disturbances, there is altered absorption of subcutaneous insulin. So what are the factors you keep in mind, Dr. Sweety, before going ahead with the pre-op phase?
Yeah.
I mean, in the pre-op phase.
So quickly, even though this talk is about a post-operative glycemic management, but for basic factors which need to be kept in mind while we're taking a history of a patient, a diabetic patient admitted with surgery. So we need to know about the type of the procedure, whether it's a short outpatient procedure or it's a long procedure, which would also determine the number of missed meals, when the patient stops eating, and when he can resume eating after the surgery. All this would help us devise a plan for the glycemic management of the patient. Also, type of anesthesia involved. We all know that epidural anesthesia doesn't affect glycemic control hugely, but certain general anesthetic agents like isoflurane and halothane might themselves cause a hyperglycemia. Subsequently, so establishing a correct diagnosis of diabetes, especially that of type 1 diabetes, is extremely important. That message has to go across clearly because type 1 diabetic patients have a risk of getting into DKA in the absence of insulin. So they would need a basal insulin at all times, irrespective of their oral intake. Of course, the pharmacological regime of the patient has to be documented. Baseline glycemic control is important, and elevated HbA1c level predicts increased risk of perioperative infections and worse surgical mortality. Of course, another important point, very important point to be noted is the presence and frequency of hypoglycemia in the patient. That would necessitate a reduction of drugs on the night before surgery for this patient. And of course, more diligent monitoring also. So now, Dr. Neelam, what are the targets for glycemic control when the patient is admitted to the hospital?
It is a little debated aspect of glycemic targets in post-op phase. There have been number of well-designed multicentric trials done in surgical and medical ICU patients where they have compared conventional or standard insulin therapy with intensive insulin therapy. And they have noticed that though the infection rates were better, infection control was better in intensive insulin therapy, but there was increased mortality and there were increased number of hypoglycemia. And there is no evidence to support the use of intensive insulin therapy in these ICU patients. So the Endocrine Society guideline says that pre-meal blood glucose to be targeted less than 140 milligram per DL, random blood glucose less than 180 milligram DL for non-critically ill patient. We can keep lower glycemic targets in selected patient without evoking more hypoglycemias, and terminally ill patient can achieve little higher sugar where they have low life expectancy or high risk of hypoglycemia. And AD also recommends that it clearly says that start insulin for persistent hyperglycemia if it is above 180 milligram and per DL, and target glucose should be maintained between 140 to 180 milligram for both critical and non-critical patients, though target of 110 to 140 milligram may be appropriate for selected group of patient. So what are the various strategies you adopt for controlling glycemic control in pre-op phase?
Yeah. So before we discuss that in detail, one point which I really want to bring home, especially in the presence of eminent surgeons here, is I know it might not be possible, but an effort has to be made to schedule the surgery of a patient with diabetes as early as possible in the morning, in an effort to minimize the disruption of the routine glycemic regime of that patient since they have to remain fasting for a long period of time. So we'll approach it in this way. Patients with diabetes who have been treated with diet alone, generally they would not require any add-on treatment perioperatively. Of course, the blood glucose must be measured and monitored. For those who are undergoing short surgeries might not need supplemental insulin at all, but those who have a long surgery like a CABG or an organ transplant where an intraoperative steroid use is anticipated must be monitored both intraoperatively and given supplemental short or rapid-acting insulin as required. Patients who have been managed on OADs at home and have been doing well can actually continue to take their OADs till the night before surgery, except SGLT2 inhibitors, which as already discussed in one of the talks is associated with an increased risk of euglycemic ketoacidosis. So there are various guidelines. Some of them say that they have to be stopped around 3 days prior to the surgery. On the day of the surgery, most of the OADs must be stopped, apart from very small, short surgeries where the patient is anticipated to start eating soon after the surgery. Therein we might continue drugs like thiazolidine-diones, metformin, and DPP-4 inhibitors. We should also all remember that metformin itself is not associated with any increased risk of lactic acidosis, but it might worsen the risk in patients who are already predisposed. So it makes sense to withhold metformin in patients who are either supposed to undergo an IV contrast procedure or who have been admitted with a declining renal function, sepsis, hypotension, or organ failure. On the day of the surgery, again for short surgical procedures, we might not require insulin at all. Blood glucose monitoring is imperative. For those who do get hyperglycemia, a supplemental short-acting or rapid-acting insulin must be given. Now, for patients who have type 1 or insulin-treated type 2 diabetes, how do we manage them preoperatively? Most of the patients can stick to the same regime till the night before surgery, provided they have been well controlled on that earlier. Otherwise, they would need an optimization. For those who have a history of recurrent early morning hypoglycemias, we might consider cutting down the nighttime basal insulin dosage by around 25%. On the morning of surgery, obviously all prandial insulin has to be stopped, but those on basal insulin must continue to take it at around 75% of the dosage if it is a long-acting peakless insulin and 50% if it is an intermediate-acting insulin. On the day of the surgery, obviously blood glucose has to be checked frequently, especially if it is falling. Dextrose infusion has to be started to avoid starvation ketosis, also in patients with type 1 diabetes who would continue to be on some form of insulin continuously. And for those patients who do develop hyperglycemia along the procedure, must be given a supplemental short-acting insulin. For those where a complex prolonged procedure is anticipated, the best thing is to start an insulin infusion, which can be easily titrated to achieve target glucose levels. Intraoperatively, again, for long procedures, blood glucose monitoring should be done, and insulin infusion initiated if levels are more than 180 milligrams per deciliter. So, Dr. Neelam, once the surgery is done, how do we deal with these patients in the post-operative period?
So post-op glycemic control depends whether the patient is non-critical in ward or daycare patient, or is it a critical or ICU patient. So post-op type 1 diabetes should always be treated with insulin even if patient is NPO. If there is a poor oral intake, it's just basal insulin with correction insulin every 4 to 6 hour blood glucose simultaneous checking. If the patient is accepting all the meals, basal and prandial insulin along with correctional doses of subcutaneous insulin is required. And patients who are on post-op type 2 diabetes on OHA, once the patient resumes eating, the pre-op regimen can be instated in minor procedures. And metformin not to be restarted only in those patients who have renal insufficiency and CHF, as Dr. Sweety has already told. Pioglitazone not to be used in patients develop CHF and fluid retention. And SGLT2 inhibitors should be avoided in admitted patient during the immediate post-op period. And those patients who are not able to achieve their target sugars on OHA, for example, those who are on sulfonylureas and other SGLT2 inhibitors, DPP4 inhibitors, a basal bolus insulin regime has to be instituted. And post-op ward patients, those who are insulin naive before admission who are on OHA, based on their nutrition status, insulin regime can be designed for them. So those who are NPO or on liquid diet, they can be on basal insulin along with correctional rapid insulin. And then we also, to avoid any hypoglycemia or hyperglycemia, we also look towards the patient factors, such as if the patient is insulin sensitive, that is they are elderly, more than 70 years of age, they have renal compromise, then insulin lesser dose will be started, that is 0.1 to 0.15 unit per kg body weight per day. If there is no such reservation, then it will be standard 0.2 to 0.25 unit per kg per day. And if they are insulin resistant, which is BMI greater than 35 kilogram per meter square and on steroids greater than 20 milligram, they will be initiated on double the dose, standard dose, which is like 0.3 unit per kg per day, and correctional rapid acting insulin would be given. We would test blood glucose every 6 hours, and as we see that it is above 180, correctional insulin regime will be also applied. Then patient when resumes oral consumption, they accept all their meals and basal bolus regimen will be offered, and basal dosing is almost similar based on the patient factors. Prandial insulin will be like 50% of the total daily dose, which will be equally divided into 3 major meals, and along with that we will be testing blood glucose meals at bedtime and along pre-meals, and if it is above 180, we will treat accordingly with correctional insulin. Correctional insulin is basically a short rapid acting insulin added to usual pre-meal insulin patient on basal bolus regime to correct pre-meal glucose excursions, and it depends on the amount of insulin which we use, depends on the degree of insulin sensitivity, patient caloric intake and glycemic target. This is the same correctional insulin scale which we were discussing. So those who are insulin sensitive, lesser dose can be offered. If they are insulin resistant, higher dose can be offered as per the glycemic range. So Dr. Sweety, what is your take on sliding scale, which is often used still in hospitalized patient?
Yes, the surgeons would know that. So yes, I think it's an easy getaway for most of us, but a routine use of sliding scale insulin is to be strongly discouraged in the inpatient setting. The major problem here is that we are treating the hyperglycemia and not preventing it. So it delays administration of insulin and causes obviously wide fluctuations in blood glucose level. It can be really dangerous in patients with type 1 diabetes because sliding scale insulin does not use a basal insulin dosage, and there is a risk of precipitating a decay in these patients in the absence of a basal insulin. The only probable role for a sliding scale insulin in the hospital could be like a dose finding strategy when we don't know what the dose requirements for a patient who is primarily NPO after surgery would be. And we have the Rabbit2 trial, most of us know about that, that when compared with a basal bolus regime, sliding scale insulin was associated with increased risk of postoperative wound infections. Now, Dr. Neelam, we talked about the routine ward patients, but what about the critically ill patients after surgery?
So those patients who are critically ill or hemodynamically unstable after large surgeries, major surgeries, complicated ones, insulin infusion has to be started, and all hospitals should have a predefined insulin protocol which should be used in ICU. So this is one of the example that when we are seeing a patient whose target sugar is above 180 milligram, we have to start infusion. We can use this simple formulae that we can start the bolus dose to saturate the insulin receptors and the insulin tubing. So it is blood glucose minus 100 minus insulin sensitivity factor. If we do not know in advance, that is 40. And starting after the bolus dose, we can start at the rate of blood glucose, whatever the blood glucose is there in milligram per dl per 100 is equal to whatever dose per hour. And blood glucose has to be checked per hour, and as per this table, it can be titrated up and down. And this is one of the example. The hospitals can have their own predefined ICU protocols. The biggest fallacy which we see is as soon as the sugar comes down below 100, the insulin is stopped, and for a couple of hours sometimes it is not checked. It leads to rebound hyperglycemia. Then again a very high insulin unit rate has been started, and this hyper keeps happening. So we should use this protocol so that the trained ICU staff applies it and there is no more major fluctuations. Once you get towards 110 to 140, you should reduce the rate of the insulin. And if it is going below 70, more frequent sugar checking is required and glucose administration to correct the glucose levels. And before we shift the patient, we have to make sure that the patient is not stopped on IV and suddenly shifted without transitioning. So I think there's lack of time, so we'll just...
So transitioning to subcutaneous insulin is probably which most of us would be interested in. Once the patient starts eating orally, we have to transition him or her to subcutaneous insulin. For that, we need to calculate the total daily dose of insulin for that particular patient. So the way to do it is to calculate the insulin dosage requirement in the last 6 hours while the patient has been on an IV infusion, provided that his blood glucose levels were stable in that period. Because obviously if the blood glucose have been fluctuating and the difference between consecutive insulin infusion rates have been more than 1, that would not be an ideal calculation. So we would want to wait and reassess for another few hours in that case. The total daily dose then comes to 80% of the insulin used in the last 6 hours multiplied by 4. That's a 24-hour requirement. Of course, if the patient has already been on dextrose infusions, we have to consider that if it must be stopped, then it comes to 60% of the total insulin required. This is then divided subsequently into prandial, basal, and correctional components. So the dosage here, the division is based on whether the patient is eating or not. So for patients who are not taking anything orally or are only on clear liquids, 50% of the total daily dose has to be given as a basal insulin, and the remaining, obviously they don't need a prandial component, but despite that, if the blood glucose is persistently more than 180, 25% of the total daily requirement can be divided into 3 parts as a prandial dose. All of them would need a correctional component based on blood glucose recordings. Those who are eating will get 50% of the total daily dose divided into 3 equal parts at meal times in addition to the correctional component. And as Dr. Neelam said, the point not to be forgotten is subcutaneous basal insulin must be given at least 2 hours prior to shifting the patient to before stopping the IV infusion, and shift the patient out of the ICU to the ward only once the transition has been made. Quickly about hypoglycemia, Dr. Neelam, on the practical points.
So we have to definitely identify risk factors leading to hypoglycemia so that no more hypoglycemias happen and subsequently. Often causes are reduced oral intake, emesis, reduced rate of IV dextrose, inappropriate timed insulin, any renal dysfunction or sudden reduction in corticosteroid dose. We have to document all the hypoglycemias carefully and timely monitor, identify the cause and rectify, and reschedule always the insulin or OHA appropriately. And otherwise, it can lead to life-threatening complications in patients who cannot sense hypoglycemia post-surgery due to influence of sedation and anesthesia. So prevention is important in high-risk patients. Frequent monitoring is required. We should have a clear-cut protocol to correct it. Special
I think we are
consideration.
running out of time. We'll quickly go through the special situations. Steroid therapy we know associated with increased blood glucose levels and increased insulin requirements. So based that most of the patients are well managed only on a basal bolus insulin regime, especially if they are either on a high dose of an intermediate acting steroid or a long acting steroid. And one of the strategies here is if a patient is already well controlled on an OHA, we might just add an intermediate acting insulin, because the peak effect of prednisolone is seen at lunchtime. So the effect of the NPH and the steroid can coincide there. Patients who are on enteral and enteral feeds and TPN again would need, for TPN patients we can calculate the daily insulin requirement and just add it onto the TPN along with correctional doses as required while we monitor them. For patients who are on enteral feeds, if they are on a continuous NG feed, again the strategy is to give them a basal insulin and check blood glucose 6 early, give a correctional insulin as and when required. For those who are on bolus feeds, it becomes very difficult to give a bolus insulin dose every 2 early. There we might make an attempt, if possible, to plan the feeds as 3 major and 3 minor feeds, like we would do in a patient who's eating, wherein it would facilitate bolus insulin doses at meal times or along with the major feeds. For emergency procedures, I think the take-away point here is that insulin infusion is preferred. Most of them would be not well controlled. Only in case of a DK, we might consider deferring surgery. Otherwise, we can go ahead with a well-planned insulin infusion and frequent monitoring. Most important, I think, discharge advice, Dr. Neelam.
So discharge advisory is most important essential component, and depending on HbA1c, if it is less than 7, same pre-op regime can be continued and patient can be discharged if not contraindicated. If it is more than 7, then it requires intensification of either OHA or insulin or both, and patient who have severe symptomatic hyperglycemia, and then basal bolus insulin should be instituted. And post-op blood glucose control is equally important as the admitted duration time, because it affects proper wound healing, especially the immediate first 2 weeks of discharge. Patients should receive very clear advisory on diabetic diet, insulin injection technique, insulin dose adjustment, hypoglycemia symptom and management, proper blood glucose monitoring and charting, which is very, very essential and often sometimes ignored or not adequately emphasized. And we should ensure that diabetes team or diabetic educators, dietitians, they should be roped in from the beginning and ensure proper consultation. Don't forget to schedule follow-up appointment with clinician or endocrinologist or whosoever is looking after the blood glucose of these patients, and they should present with the proper blood sugar log within 3 to 7 days of discharge for optimum blood glucose control. So to conclude, optimal insulin therapy remains the cornerstone of glycemic management of diabetes in peri-op phase for improved surgical outcomes, and we have to maintain target of 140 to 180 but without evoking unacceptable glucose fluctuation and hypoglycemia, which may affect their prognosis.
And of course, achieving a good glycemic control is not only the endocrinologist's job. We all have to work together, involve people at the right times and ensure continuity of care. And most importantly, written protocols, especially in the ICU setting, which would help the staff move in the same direction as us. And finally, one more thing which I want to emphasize is that hospital is probably the most receptive phase for a patient, where he or she would be able to make life-lasting decisions regarding his or her glycemic control. It's a time to empower the patient, not only for the other primary problem for which he has been admitted, but for a long-lasting disease like diabetes, and that opportunity should not be missed.
And I'm sure many times all clinicians, whoever sitting here, must have experienced that many times when the patient is leaving, we get a frantic call from the nurses that patient is leaving, kindly suggest something for diabetes. So that gives very less scope for any engagement with the patient, because he is in a hurry to do discharge formalities. So maybe little early involvement would be benefited.
Good, very nice talk. And the tagline is that case should not be cancelled for high blood sugar if it can be controlled. Any questions from the audience? Yeah, Mahadevans. Yeah.
You have packed too much information
probably the time was too little,
Time
but
and then
Yeah, but
transition.
the
a
topic
lot
was
of
very informative.
relevant points, yeah.
Yeah, you have almost covered it all, and the
Yep.
take-home message which you have is everyone is on the dais right now: endocrinologist, anesthetist, and surgeon. So we should work together in the team for the benefit of the patient always.
I have a question, if I may.
Yeah.
What do we do with the basal insulin when we are discharging a patient on steroids and then gradually tapering? For example, in the COVID scenario, we were discharging, we were giving 40 milligrams in hospital,
Yeah.
and at the time of discharge, we converted to 24, 20, 16, 8, 4. So what do we do then?
Right, so we could emphasize too much on the glucocorticoid part because of lack of time. But yes, anyone who is on a steroid would need tapering. And so the emphasis here is on keeping in touch with the primary team or the glucose managing team, because as the steroid dose has to be is tapered, his or her insulin requirements would change. And it wouldn't be a basal alone, a basal bolus on which he or she would be discharged. So I think frequent monitoring at home. And
With fasting, you can do little dose adjustment. You can explain the patient if it is going below 80, they can reduce it by 2 units. So some dose insulin adjustment advisory can be given to the patient, but they have to be in touch with the team.
a written correctional scale can be given to them, but it would also need timely
Follow-ups,
follow-ups.
yes.
Okay, any more queries? And that will follow in the dinner, which is about to follow. So let's close this session.
Sorry
and
for delaying
thank you.
dinner for all of you.
Thank you.
I
very
was
much.
interested in one session, so we give you enough time to cover that. Thank you.
Thank you. Thank you.